Welcome to our seminar today. This is a seminar that happens every month. Every week. And so Marie and I have the pleasure today to bring a colleague from the Pacific Northwest, and I have the pleasure to introduce Jonathan, one of assistant professor in global health, who's going to introduce our speaker for today.
Yeah, good afternoon. Again, my name is Jonathan Garcia. I'm in the Global Health Program. I know many of you, especially some of the students here to represent. So I'm here to introduce Dr. Ornelas. She's the Research Director and Assistant Professor in the Department of Health Services at the University of Washington's School of Public Health. She currently serves as the Research Director of the Latino Center for Health, and her research focuses on how social and cultural factors influence health and the development of interventions to address Latino health disparities across a variety of outcomes. Dr. Ornelas received her MPH from the University of Washington and her PhD in health behavior and health education at North Carolina Chapel Hill. And without further ado, I will let Dr. Ornelas guide us through her presentation on community engagement in addressing some of Latino health disparities.
Great, thank you so much. I've really enjoyed my visit to Oregon State so far. It's been a very warm welcome, and looking forward to meeting with more students and faculty this afternoon. So I just wanted to tell you a little bit about the Latino Center for Health before I start. We are a relatively new center, and we're focused on community-engaged research and policy-relevant research. And so we are actually funded by the state legislature in Washington, but very interested in working regionally across the Northwest on Latino health issues. And so it's been really fun today to talk about potential collaboration opportunities here at Oregon State, and would welcome more conversation about that in the future. And also, if anyone has questions about that, I can talk about that more at the end. So today I'm going to give you a little bit of a background on Latino health disparities, specifically mental health and substance use, which are two areas that I work in. I use a theoretical framework called stages of migration, and we'll talk to you about how do the different stages of migration influence health. And then I'll highlight two different interventions that I've been working on developing. One is called ALMA, Amigas Latinas Motivando el Alma, or Latina Friends Motivating the Soul, which is focused on preventing depression and anxiety in Latina immigrants. And the other is Vida Pura, which is an intervention focused on reducing unhealthy drinking in Latino day laborers. And then I'll close with some thoughts on future directions for my research. So Latinos are the fastest growing racial ethnic group, both in the US, in Washington, and in Oregon. And actually, as I was updating these slides to change them from Washington, where I usually give this talk, to Oregon, I didn't have to change very many of the numbers. Our states are very similar. So Latinos are 12% of the state population in Washington and Washington, and that compares to about 17% of the population in the US overall. We also have a similar balance of U.S. born versus foreign born. So 34% of the Latino population in Oregon are immigrants, same in Washington. And I think both states have traditional settlement areas, which are places where Latino immigrants have come for many years, where especially the farm working communities, but also these new destinations where we're seeing more first generation, so more in the cities. In Seattle, that's more in Western Washington. It probably has a little bit different pattern here in Oregon. And we know that Latinos are at increased risk for depression, anxiety, and substance use disorders, and that risk and the prevalence increase over time in the U.S. And that's a pattern we see among people with the amount of time they spend in the U.S. In terms of years, but also a pattern we see across generations. So the second and third generation having higher rates than the first generation. And unfortunately, we also know that Latinos are less likely to access and utilize healthcare than other racial ethnic groups due to economic, social, and political barriers. So one of the common ways of thinking about Latino immigrant health is this idea of the Latino paradox, which many of you may have heard of. And it's called the paradox because immigrants tend to actually have better health than their US-born counterparts, despite having lower socioeconomic status. So that's an unexpected pattern. And despite that sort of advantage that immigrants come to the U.S. with, we see that their health tends to get worse with increased time in the U.S. And that is seen through a number of health conditions: obesity, diabetes, cancer, and substance use and mental health. Previous research has focused on acculturation as an explanation, that there's something that changes with more time in the U.S. So as immigrants acculturate to the culture of the U.S., they're losing something protective about the country, the culture that they came from, or the culture of their country of origin. And or that their immigrants are adopting unhealthy behaviors that are associated with American culture. So sort of either cultural or behavioral explanations. But my research really tries to unpack that pattern and that phenomena of acculturation. So how are the social and historical contexts influencing patterns of health that we see in Latino immigrants? Where are immigrants coming from and why? What motivated their decision to migrate? What are the changes in their social ties and networks? Did they come here alone, or did they come here with other family? How much contact do they have with family back home once they come here? And what are the new social ties that they make here in the U.S.? How are racism and discrimination influencing their lives? How are immigrants adopting a minority or being racialized for the first time and becoming a racialized minority for the first time if they came from a country where they were the majority? What are their experiences navigating discrimination and institutionalized racism, and how do those influence health? And then immigration policy. How are immigrants able to access the benefits and legal protections associated with citizenship, including access to health care, or even beyond those that may not have legal status and therefore access to health care? Everybody, all Latinos are influenced by anti-immigrant sentiment and immigration policy. So just even acceptance by mainstream U.S. culture and the current social and political climate. And then, of course, there are real stress and coping responses to all of these immigration stressors that happen after you immigrate to the United States. So as I mentioned, I use a theoretical framework called Stages of Migration. And most of the research on Latino immigrants in the U.S. has focused on their life after they come to the U.S. So we focus here post-migration, and we don't really take into consideration what's happening pre-migration and during migration. And we know that these two stages are also really important. So the Stages of Migration framework helps us understand that what was the social context that actually motivated people to immigrate? Were they coming out of extreme poverty? Were they coming because they had been experiencing violence or war? So what was happening to them before they migrated? What was their socioeconomic status, and how did that change? During migration, lots of things can happen to you too. Did you fear for your safety or stress as you made that crossing? Did you experience traumatic events? We know that people that migrate often are exposed to physical abuse and sexual abuse, especially women, and that entering without documentation can be a really dangerous and risky experience. And then, of course, we are still interested in what happens post-migration. What is the exposure to discrimination? What are the types of neighborhoods that immigrants move to, and how are those either promoting their health or increasing their risk for certain health problems? Are they moving into neighborhoods with other immigrants, and is that protective, or does that restrict them from resources and isolate them in some way? How are they adapting to language changes? Are they learning English or not, and how is that impacting their isolation? And then, of course, family separation. Many parents are separated from their children when they migrate. If they migrate separately from their children, there's often, sending one person in the family first, and then other family members come as they gain more resources. But there's also an opportunity for family reunification, which can be a positive thing. So I've sort of used this Stages of Migration approach and examined it through a series of several different papers, using some large national data sets like the National Latino and Asian American study, where I looked at gender differences and discrimination and substance use disorder among Latinos. So I've focused in these two papers on one particular immigration-related stressor, discrimination, Also did a similar study on binge drinking and discrimination among Latinos in the study of Latinos. And then also actually tested all 3 stages of migration in this paper in Social Science and Medicine, where we're looking at the development of depressive symptoms among Latino immigrant parents in North Carolina. So in addition to that sort of more quantitative work, I also have done some more qualitative work, which has told a similar story around the importance of these different stages of migration and around discrimination in particular. And so when I first started my postdoc in Seattle, I wanted to learn more about the Latino community in Washington State and sort of what their immigration-related stressors were. And so I did, with the help of some research assistants, 46 in-depth interviews with a diverse sample of Latinos living in both Western Washington and Eastern Washington, both foreign-born, U.S.-born, English-speaking, Spanish-speaking, to really understand sort of how they were experiencing their life in the United States and whether there were differences. And I really found that discrimination due to legal status and language was very common, and these are 2 dimensions of discrimination which haven't been typically measured a lot in the discrimination and health literature because a lot of that literature has focused on African Americans. I also learned that a lot of Latino immigrants were sort of walking around with this sense of hypervigilance and anticipatory stress, and this is a direction that a lot of the discrimination and health literature is moving now, where we're not even worried about actual experiences of discrimination, although those are very bad, but also just worrying, walking around in the world worrying when that could happen to you. And I think in the case of, undocumented immigrants, that's a really huge fear. And, in this climate, just a fear for all of us where people have become emboldened to actually be more expressive about discrimination. And then I've also found that women and men sort of experience the health effects of discrimination and other immigration-related stressors differently. So as these quotes illustrate, for women, it tends to show up more as depressive symptoms and mental health issues, and for men, it tends to show up more as substance use. And this is a pattern that I don't think is particularly unique to Latinos, but I think, important to kind of consider the role of gender. So this woman, the worry, I worry, these are translated. I have some in Spanish and some in English and some in both, but these are actually translated from Spanish. It's the worry, I worry, when is immigration going to come? Because I'm mojada. And your experience, all that it has cost you to come here, and that they could just send you back. It's that worry, and at times it affects you. It can affect your health. And this man is saying, I know some friends that do smoke and drink, they are addicted to it because of stress, and that calms them down. It's like drinking and using drugs. Maybe when they feel that way, they turn to those things. So after I had done a lot of this work, sort of understanding this phenomena, these different stages of migration, I, of course, wanted to go to the community and think about community-based interventions that might help address some of these immigration-related stressors. And so I began building relationships with community partners and was asking them, what do they see as the health priorities in their community? And was also, as a researcher, thinking, okay, what are some of the existing interventions that I might draw upon to help address some of these mental health and substance use disparities that I had seen? And this is a picture taken in one of the community-based organizations that I work in a lot, called Casa Latina, and it's a day labor worker center in Seattle. So men go there, get entered into a lottery to get day labor work. They show up Monday through Saturday, often 40 to 50 men, and then they're sent out on jobs. And people like you and me could call up if we need a gardener or a painter or a landscaper, and they are matched up with jobs and they have set rates. And so they sort of act as a middleman, and it's providing economic opportunities for the Latino immigrant, mostly men, there are some women, but also sort of establishing, again, fair rates. And so these are 2 of my research staff that are talking about one of our studies, the Vida Pura study. So they confirmed that mental health and substance use were indeed important issues. And when I thought about mental health, one of the first interventions I thought of was one I had helped develop when I was a PhD student in North Carolina. So there had been a huge wave of immigration to North Carolina in the Southeast back in the 1990s and 2000s. And one of the things that I had helped develop as a doctoral student was the ALMA program. And it was a program to prevent and reduce stress and depressive symptoms among Latina immigrant women. and really to promote self-care and social support. There were weekly group classes over a series of, we tested different lengths, 5, 6, 8 weeks. And they were conducted in Spanish, led by a master's in social work. And they were also sort of bringing the group together, a group of women together that didn't know each other, and also helping them, tie them to resources in the community. Because in North Carolina, again, it was a particularly new group of immigrants that hadn't been in that state before. So the topics included things like understanding what stress is and how it impacts the body, the impact of migration on emotional health and social networks, healthy ways of coping with stress. We introduced them to things like yoga and mindfulness, sort of things they could do easily at home themselves, and then also talked about how to seek mental health treatment if needed. And so we piloted this, when I sort of took this intervention, the idea of this intervention to the community, and I said, is this something you'd be interested in? And they said, yeah, let's give it a try. So we piloted it in Seattle. And the first pilot I did was very small. We just did 5 sessions. It's very interactive. We did it with an existing women's group that Casa Latina ran, a sort of women's empowerment group, just to see what their response was. In the original intervention in North Carolina, we had a comfort basket, and we would give some women something to put in their comfort basket every week. Well, the women in Seattle didn't want a comfort basket, they wanted a comfort toolkit, and so this was, or toolbox. So this was the first thing we did the first day was they made a toolbox. They decorated their toolbox, and then we gave them things to each week to kind of help them, remind them about the topic that week. So we're trying to, again, build on that idea of transnational support and social support. How can you still stay connected to people back in your home country, writing cards to people, doing an exercise with yarn to sort of illustrate a web of social support. We incorporate dichos that people might say, that sayings from, their grandmother or mother might say about sort of more indigenous ways of coping that they're already used to, before then also sharing these new ways of coping. And so this is just some photos of what the group sessions looked like. And here we're introducing them, getting at them yoga mats and introducing them to doing a guided relaxation. And then the last session, again, focused on where they could seek mental health services if they wanted to. So we brought in actual Latina Spanish-speaking therapists that worked at these different agencies so they could see who they would be meeting with if they actually did go seek services, trying to destigmatize that whole process. And we found pretty good results. In the pilot test that we had done in North Carolina, we saw reductions in depression and perceived stress, and also increase in active coping. And we also did a session with, in the pilot test we did in Seattle, saw similar results, and were encouraged. And one of the things that the women said we also did a focus group in Seattle afterwards to figure out what they liked about the program. And one of the things the women said was they really liked the yoga and mindfulness pieces. It was something they could do themselves at home. And so there was a center on campus at UW that happened to be wanting to increase research on mindfulness and had a pilot funding opportunity about 2 years ago on mindfulness. And so they had, ever since we did this first ALMA, the women kept asking, when are we bringing ALMA back? When do we get more ALMA? We want more ALMA. And so I finally saw this pilot call and I applied for more money. And we actually did a separate kind of version of ALMA where we just did 5 sessions that were more focused on yoga and mindfulness. And this just gives you a sense of what the women are like. And this is pretty representative of other pilot work we had done with this population. So they had been in the US on average about 12 years, pretty low levels of education. Most were married, pretty low levels of income, and most were speaking mostly Spanish. And all of these sessions are done in Spanish. And, the 5 session, we're still seeing some good, pre and post changes that indicate some improvement in depression and anxiety. And a lot of these women are actually sort of walking around with pretty clinically significant levels of depression and anxiety, but just kind of soldiering through it and not ever getting mental health care and treatment. So here are some quotes and some pictures of the The recent intervention we did, the most useful classes were on yoga and meditation. I really liked yoga because it helped me rediscover myself and my values. It helped me to meditate in my own space and change my thoughts to be more positive. And another woman saying, I use the meditation exercises. I work as a housekeeper, and when I have time, I do some of the exercises that I learned. I also go to the park where there are trees and just watch the birds and feel the wind. So really trying to focus on the sort of mind-body awareness, which I think is particularly important for Latinos who tend to experience depression somatically in the body. So that's a little bit about Alma. Now I'm going to turn to Vida Pura. And you can see here that the PURA part is also an acronym. We love our acronyms in public health, which stands for Puede usted reducir su consumo de alcohol. You can reduce your alcohol use. And it's also a play on Pura Vida, which is a Costa Rican phrase. And we just kind of switched it up to mean, hopefully living a pure life, healthy life with less alcohol use. So binge drinking and unhealthy alcohol use was quite common among Latino immigrant men. And so this intervention was a different approach. Instead of sort of developing something very culturally grounded from the community up, in this intervention, an evidence-based intervention and doing a cultural adaptation of it, making it more appropriate for the population. And so screening and brief intervention is an intervention that's used in primary care, in emergency rooms. You are screened for your alcohol use. So you fill out a questionnaire to see how much you're drinking. And depending on how much you're drinking, you might get a brief counseling session from your physician or some other clinician in the clinical setting. And so this has been shown to be pretty effective. It's recommended by the U.S. Preventive Services Task Force to be happening all the time in primary care, although it doesn't happen all the time. So I wanted to see if this was an intervention that might work for Latino day laborers. And here's a great list of co-investigators and collaborators that I worked with. And again, this is something we've worked with Casa Latina on. And so in this, we're using a 5-stage process laid out by Barrera and Castro for culturally adapting an intervention. The first phase is to gather information and identify sources of mismatch between the original intervention and the new target population. So how do we think that evidence-based intervention is going to work in our new population? What might be some of the issues? And I did that in 2012, interviews with some day laborers and also social service providers working with Latino immigrant men. And then came up with a preliminary adaptation design, which I'll show you. Did a pilot test of that in 2013. And then you refine the intervention as needed. And now I'm just finishing our pilot randomized trial to determine its efficacy. So in that first stage, we asked the men about how they were, what were their patterns of alcohol use, and what was the context of their drinking, and found that it was indeed common, that it was often used to help relieve immigration-related stressors, as you can imagine. So the men really had limited knowledge about what actually constitutes unhealthy drinking, and were not unsure of how to change their behavior. So they didn't actually even know, even though they were drinking at very high levels, that was not good for them. I will tell you why I drink, because I am far away from my family. I live on the streets and all that to give me courage. And so there were really actual, important benefits to their alcohol use. They talked about being more social. They talked about speaking English better. So there was a lot of ways that this was actually helping them, although also harming them. And then we also asked about intervention delivery. So how would you want to receive services if you got services? And the men said they preferred to receive them from trusted providers in Spanish. Well, the important thing is that we do need that kind of group or program, especially because sometimes we do not attend programs in America for the same reason. We do not feel comfortable with others, or we may not understand. We cannot communicate. And then last, we asked about administrative and community factors that might influence the context in which how this intervention got implemented. and found out that men face a lot of barriers to accessing health and social services. Most of the men we talked to had never actually sought any kind of health or social services other than going to the ER in the US. Few programs actually provide culturally appropriate alcohol-related services, but the men were open to receiving something like brief intervention, a brief counseling session in community settings. We prefer to carry our pain than to heal, because I can't. I have no money to do it. If, well, there is a place with programs where they start to increase your awareness and help you with all of these types of problems, well, it would help a lot. And this other man is saying, people are afraid, actually this is one of the providers is saying, well, people are afraid that if they access any resources, if they're undocumented, they will be deported. That's the big thing here. If you access any public funding, you're going to be on a list. So even though that's not true, that was the perception. And so this model of cultural adaptation actually lays out for you these three areas. I didn't just come up with that on my own. Looking at the group characteristics, the intervention delivery, and the administrative and community factors. And you can kind of make this matrix where you're looking at, okay, what did we find? The themes in the first column. How does that match or mismatch the population I want to adapt this intervention to? And then what do we actually need to adapt? What is the adaptation? So from what we found out about the drinking patterns of the men, it seemed like brief intervention that provides about personalized feedback, since the men didn't really know how much they were drinking, and increases their awareness and offers culturally relevant strategies for reducing drinking would be a good match. So we knew that the format and content of the brief intervention really needed to incorporate that social and cultural context. We couldn't just recommend that they go to treatment, inpatient treatment for 30 days, right? That's not going to be a relevant strategy for them. But can they reduce their drinking? Can they walk home a different way and not walk by the bar or the mini mart that sells alcohol? What are some kind of more appropriate strategies? And then for intervention delivery, we found that the men prefer to receive information from trusted providers in Spanish. So a brief intervention that's provided by a healthcare provider, as it's typically done in a clinical setting where the providers can't speak Spanish and don't really have an awareness of culture, that's probably a mismatch. And so our adaptation was to have the brief intervention delivered by promotores in Spanish. So people that were sort of paraprofessionals, lay health workers that were trained and had educated, still could relate to the men. And then in terms of administrative and community factors, we knew that the brief intervention, again, offered in healthcare settings, really would be unlikely to reach those that need it. And we knew that one part of brief intervention is often also referring to care or treatment if needed. And we knew we needed to refer to truly accessible services, since the men were facing a lot of barriers to accessing services. So our adaptations were to conduct the brief intervention at a day labor worker center where they are already familiar and felt comfortable. And then we did identify services that were low cost and in Spanish that we could refer them to. So there was a local clinic that had a program, a screening and brief intervention program funded by SAMHSA at the same time. And we did sort of a warm handoff to that clinic if the men wanted to be seen. So in summary, we're sort of retaining the core elements of the brief intervention that we know work, that personalized feedback, using motivational interviewing to assess readiness to change and sort of elicit behavior change. And then it usually ends with negotiating a plan or a goal, identifying strategies and offering referral information. And then the things we adapted were using the promotores, doing it in the day labor worker center, and again, that referral to low-cost Spanish-speaking services. So here was what the first version of Vida Pura looked like. We had we actually had we had some students going out, but these were two of the promotores that ended up working most consistently, Edgar and Victor, and they went to the day labor worker center. And this was a handout. It was just one sheet. This side was like one sheet that they would use to talk to the men about their drinking. This is an audit pyramid, which is a pretty commonly used pyramid to explain your alcohol risk. And again, mostly used in clinical settings. So people in the green are considered like not at risk or abstinent. And then this is the screening instrument we use. So we ask questions and you get a score based on the audit. And people up here in these levels and these point values are at levels of high risk or abuse or dependence. And so we would write the men's audit score up in the yellow box and show them here on the pyramid where they fell. We also were sort of focusing on the NIAAA recommendations of no more than 14 drinks per week or 4 per day. That ended up being pretty unrealistic for a lot of these men. They're drinking much, much higher quantities than that, but we felt like it was important for them to know. And so we would put in what they had said based on the survey they were drinking per week and per day. And then this ruler was just a tool for the promotor to use to talk about readiness. So you could say, how ready to change are you based on, where would you put yourself on this ruler? And we found that, I'll get to that in a second. So here's a little bit about the men that we saw in this first intervention. So we screened 100 men, and of those, 65 were at a level that needed a brief intervention. And so this is just describing the sample of 65 men that actually received a brief intervention. Average age of 45. So these are all men recruited at the Day Labor Worker Center, had been in the U.S. about 15 years. Most were single or divorced. Again, sort of similar levels of education. And I hadn't fully anticipated that half were homeless or living in temporary housing. So that was another big risk factor for a lot of the men. And again, mostly speaking Spanish. And so, as I mentioned, whereas in the general population, you might find 22% of people that are up here in these like orange and red parts of the pyramid. In our sample, that was 65% of the men. So huge, huge levels of risk. And we actually used a cut point of here, kind of a little bit lower, at a cut point of 6, because we wanted to use kind of a more of a public health approach and get as many people as possible, even people that might be kind of close to high risk. And then here are the results. So, oops. Yeah, that's right. Okay. So at baseline, they're starting at very high levels. They're starting at almost 19, so they're up in the abuse category. But at 2 weeks, we did 2-week and 8-week follow-up because we weren't sure with this really mobile population how long we would actually even be able to follow them up on. But we saw a reduction to about 13.5, so down in the high-risk category at 2 weeks, and that maintained, and they were at about 15 at 8 weeks. And so that was promising. Those were statistically significant findings. And so when I went to go then do the pilot randomized trial, I did make some adjustments. One of them was that I found out not everybody can do motivational interviewing, which is a specific kind of counseling approach that we use. And so I really tried to recruit for that and from the beginning when we actually picked the promotores. And so we wanted to pick people. These were the second iteration, Roger and Yvonne, who did a great job. We picked people that had a little bit of counseling and health education experience, obviously experience working with Latinos. They're both Latino immigrants themselves. They could build rapport easily. They had a sort of warm, non-judgmental approach, which is important for motivational interviewing. They also needed to be organized and detailed-oriented because they were doing a lot of data collection for us as well, and then obviously spoke Spanish. And so we actually had them role play how they would talk to a man about alcohol use during the interview to kind of see what they were, what kind of approach they would naturally use. And that was really helpful. And then we had more money, so we got to make it a little cooler. And we realized that the handout sheet that nobody used that. They just threw it away. The men didn't want a sheet. They didn't want to leave the room with the sheet. That just marked them as being, a drinker and a heavy drinker. And so they didn't really use that. And so we just put it all on the pad, and we didn't on a tablet, and we didn't give them anything to walk away with other than a small little card they could put in their wallet if they wanted to follow up. And so here, Yvonne, actually, one of the promotores, had a graphic design background. She helped us design these screens. So they would do the interview with one of the promotores, then they would do a handoff to the other promotor. We would separate data collection from the intervention, and the other promotor would walk through a couple of screens with them, giving them their feedback that was directly coming from the surveys they had just done with the other promotor. So again, here, instead of us writing in the box, here it says, this is a recommendation, no more than 4 per day. And here it would say what they actually said they drank. And here it would show their actual score on the audit pyramid. And then for the brief intervention piece, we had a screen that talked about their motives and consequences that could kind of be used as prompts. Again, this was information that was pulled directly from the survey. So this was all these screens were sort of stored on the cloud, and then they could just go to a website and pull up the specific person's results. And they would discuss the results with them, negotiate a plan for change if they wanted one. And this was the ruler where it would circle the number if they were ready to make a change. And so this was the design for the randomized trial. We screened 181 men, again, at the Day Labor Worker Center. If they had an audit score under 6, that was just the end of the study. We didn't recruit them. We ended up having 124 that had a score of 6 or higher, be part of a control group. And again, I guess part of the community engagement story behind this is that there was no way we could have done this randomized design in the very beginning, right? We had to work our relationship with that community partner and sort of build their trust so that they understood by the time we did this trial why it was important to randomize, why some of the men weren't going to actually get a brief intervention, and why that was important to understand whether it was effective. So another thing that ended up happening here is that we hadn't fully anticipated, even though we probably should have based on the pilot results, how many men would be at such high levels of alcohol use. And we didn't feel like it was ethical to not give them a brief intervention at all. And so once we started seeing men come in with really, really high audit scores, we made a decision that we were going to actually not have those men go into the control group. So even if they were randomized to control, we gave them an intervention. So we ended up with a lot more people in the intervention group and had to keep recruiting to fill up the control group. But we had much better rates of follow-up. I had forgotten to mention on the first pilot, but we had pretty terrible rates of follow-up, 65%. But one of the lessons learned in that first pilot was that we just needed the promotores to be on site on a regular basis. And so they went every week, 2 times a week. The staff really got to know them. The men got to know them. We actually, Roger and Yvonne actually went and just hung out at the Day Labor Worker Center for about a month before they even did data collection. And that was just really important for building that relationship and trust so that by the time they went to actually do recruitment, the men felt comfortable with them and knew who they were. And then I have a PhD student who's doing, as one of her dissertation papers, a subsample of about 20 men where she's just doing in-depth interviews with them to figure out what it was about the intervention that they liked or worked, what was their satisfaction with the intervention procedures. And so I have a little bit of data. We just finished data collection this fall, and I'm still analyzing the results to see if it worked. But the population in this second pilot was pretty much similar to what we had seen in the first pilot. They've been in the U.S. a little longer now, up to 20 years, and they're still doing day labor. So it just shows you that there's just a real vulnerable population that's never really fully integrating into the labor market, even 20 years after being in the U.S. And this shows you so this kind of shows the typical audit pyramid in orange, what we would see in the general population, and then in green is what we found at Casa Latina. And so what you see is instead of a pyramid, so you can kind of imagine this is half of the pyramid, it goes down and gets big at the bottom for the orange. But in the green, it's more of this bimodal distribution where we've got a decent amount of men that are at low risk, but a lot of men that are at the high risk. And brief intervention is actually really supposed to work for these two groups. So it will be interesting to see whether or not we see an effect because like I said, we got so many that were really already in the dependent. And this slide just shows the same thing. In that first, this is of the 181 that we screened, how, again, that shows that bimodal distribution. And then of the ones that actually got into the study that did the baseline, see almost 50% of those that met the criteria to get a brief intervention are at that highest level. So some of the lessons learned were just the importance of community engagement. I think for both studies was really critical to the feasibility. We learned in the Vida Pura especially that regular in-person phone and text contact can result in high recruitment and retention rates in a population that is pretty mobile. And we had actually planned to do the follow-up surveys by phone initially. There was no way that was going to work. They are very precious about their cell phone minutes and didn't want to use them to talk to us on the phone. And so that was, again, an adaptation that we made in the second pilot where we were like, okay, we've got to go on site. We've got to do everything in person. This phone is not going to work. Again, that high levels of dependence among the day laborers is screening and brief intervention really the right intervention. And I just did want to say on that point, there is a small day labor worker center in Portland, and we decided to do a small pilot there at the end of the data collection. We had a little extra money, and that day labor worker center, Bose, had approached us about doing some collaborating. And so they had actually come up to Casa Latina for a visit, and they were scoping out how Casa Latina was working. And they were like, who are these promotores and what are they doing? And we need these at our day labor worker center. And so we did a small pilot in Portland and found, again, really high rates of homelessness. That day labor worker center is not as well as established. And so they're pulling a lot of people from street corners or the people that live on the streets, and found pretty high levels of alcohol use in that population as well. So again, I'm not sure that screening and brief intervention is the right intervention for that group either. We really had low uptake on referrals. Men that wanted to go out and get services never made it there, not a single one. So how can we actually get men that want treatment into the right treatment, right? If there is low cost, inpatient, short treatment available for some of these men in the dependent group, but the trick is how do we get them there? And then identifying which of the immigration stressors are really contributing most to unhealthy alcohol use so that maybe we can actually get behind the 8 ball and work to alleviate some of those stressors. Or in front of the 8 ball. Is that maybe the better metaphor? No, in back. We don't want to be in front. So in terms of my future directions for Vida Pura, I will be looking at, depending on the results, either a multi-site trial, or thinking about how this might work in other community-based organizations or other day labor worker centers. The other thing I'm interested in exploring is this. Looks like from some of the preliminary data that there is increased risk for these men that are homeless or in temporary housing. So what might a multi-level intervention that incorporates housing look like? Could we do some advocacy or case management around helping the men find housing or finding shared housing that supports their desire to reduce their drinking? And planning an RO1 submission for the summer. I'm just finishing an RO1 submission, going in on Monday for doing a randomized control trial of ALMA. And so that will be an 8-session curriculum. We're going to have a waitlist control design. So we'll run it 2 times at 2 sites, Casa Latina and another community organization in Seattle called the Centro de la Raza. So we'll see. We'll see what is going on at NIH by the time that gets reviewed. And I just wanted to make a last plug for, the Latino Center for Health, and really I'm open to hoping we can find some collaboration opportunities, because I know you guys are doing a lot of great work in Latino health here too. So thank you, and I'm happy to take any questions.
Questions?
Hi.
Hello. I just wanted to ask you questions. Did you find huge discrepancies between urban and rural Latinos in depression and alcohol abuse? And also, do you have collaboration with Panache currently?
I don't work with them super closely, but I know them well. Yeah. So with the Vida Pura study, it was all just done in Seattle. It wasn't done in any rural settings. So I don't know about differences in rural settings. And I've thought a little bit, because we have a lot of Latinos that live in rural settings, what that might look like, or what might be equivalent community-based organizations, and would love any input you guys have about where this might work, other than a day labor worker center, especially for rural populations. And I'm trying to think in some of the larger data sets, the study of Latinos was all cities as well. And LAS was a phone, and I don't think I looked at urban-rural differences in that either. I mean, all of the qualitative, so there's been a lot of studies done on alcohol use in Latino immigrant men in North Carolina, and that's a pretty rural setting. and I did my own dissertation there as well, and found very similar rates. And I don't have much to say about panache, but if you have a specific question, let me know.
So we can all accept that the audit scores that you use in the American culture and American clinical settings, those are acceptable rates of alcohol abuse and so forth. What sense did you get from the Latino men of them viewing their habits, their drinking habits, as being alcohol abuse, or did they see it as acceptable?
A lot. There was definitely norms that much higher levels. Yeah. So I think there's a strong cultural norm of especially binge drinking as being something normal and okay, especially when it happens occasionally, like the fiesta drinking pattern. And that's very normative. There were men at the higher levels that definitely knew they had a problem and knew they were dependent and wanted to stop drinking and just didn't know how. So I think there was like kind of a tipping point. I'm not sure I could say what score it was, but
can I ask a follow-up?
Yeah.
So was there some negative behavior or outcome while they were intoxicated that was making them realize that this was
absolutely, and that's what you try to draw out in the counseling session, right? Is help them see how the negative consequences to the drinking are in conflict with their values, and so. Some of the common consequences that were hard were losing family relationships, broken family relationships with spouses or children, being too hungover to work, encounters with law enforcement. And so part of the problem is that they are having those negative consequences, which are causing probably depression, and so then they want to relieve the depression with more alcohol use, and then you get in that cycle. And so part of what we're trying to do, again, this is very much a harm reduction approach, is even if we can back off the drinking a little or reduce the consequences, then maybe we can slow that cycle down.
In the Pura Vida intervention, the second time that you did it, and you had a male and a female promotor, how do you think there was in what ways would gender roles influence the collection of data or the counseling? And if you did you alternate who did counseling and who did data collection?
Yeah.
Or how did that work?
Yeah, we made sure that they were all getting the same amount, that Roger and Yvonne were getting the same amount of interventions and surveys so that we would have equal numbers of both. And we asked the men early on, both at the very beginning and after the second pilot, whether they cared whether it was man or woman. They said they didn't, and I think that pretty much played out. Roger and Yvonne had somewhat different personalities, but both ended up being great at MI. We had great fidelity. Actually, we recorded their sessions and coded them, and that paper is actually coming out soon. And they were great at what they did. And I think that in the end, the men didn't care whether it was a man or a woman. It was the fact that somebody sat down and listened to them that was most important. Yeah.
I have a follow-up to that question. Theme of gender. I understand women and the men are separated. They're getting different interventions.
Yeah.
But I was wondering if you could speak to whether that really is the best model. Is there a model of intervention that could bring them back together?
Yeah, I mean, obviously I'm not seeing as high alcohol use in the women. So, but I think this center on campus that was really into mindfulness, they were like, okay, we want to fund you to do more mindfulness. We want to fund you to do mindfulness with the Casa Latina staff. So actually right now we're doing another pilot where we're teaching some of the ALMA curriculum to the staff, who are also mostly Latino immigrants themselves, and a mix of men and women. And part of the idea is to kind of see if this is going to help relieve. They're receiving a lot of secondary trauma as service providers and have a lot of stress in their own lives as service providers. And so trying to see if these same stress reduction techniques work for them. And some of the staff have said during this work, the men need this. The men need ALMA too. The men need some sort of other coping strategies. So I'm thinking about that. But yeah, I think there might be ways to bring the men and women together. I think you were next.
In the ALMA program, is there any difference either in implementation or in efficacy for women that were simply or participants, I'm sure it wouldn't matter what gender, participants who were at risk for depression and other mental illnesses versus ones that's screened as having like active depressive disorders or other active mental illnesses?
We didn't have enough women, enough variation to look at that. And what I have decided to do in the trial moving forward is if they're at really high levels, is that this is not the right program for them. I'm not going to include them because I feel like people that are at really high levels probably need connection to care. So I am sort of thinking about ALMA as more for people with mild to moderate symptoms of depression and anxiety. But I think we'll get more variation in the next trial. Yeah.
So did you find with any of your participants that they wanted the involvement of their family or a close other?
The women for sure. And, the women bring their kids, they bring their moms. Yes, the family shows up. And so we have childcare for the women during the sessions, but a lot of times they would bring family. The family was visiting, or the men. I think since a lot of them are single, they have fragmented families and fragmented social ties, and so I think that wasn't. I think some of the men talk about the loss from losing those relationships because of their alcohol use, and I think they would they saw their partners as very supportive of maintaining less drinking, but when they've lost that support, due to their drinking, they saw positive social control from those family relationships. Yeah.
I didn't mean for this to tag on to that comment, but it kind of does. First of all, thanks for a fantastic overview. Second, I understand the RCT totally made sense the way you did it. I wonder if the group of men that was screened out constitutes a sort of ready pool of peer supporters.
Yeah.
Not for this study, but in the future, if these men aren't connected in other ways, they're hanging out with the men who aren't drinking.
Right.
And I don't know if you thought about
Yes,
that.
and I think that there is a role for more peer support, and I want to do more work to figure out what is going on with the men that are not drinking. Absolutely. Yeah, that's a great point. There's another one. Yeah.
Thank you, Dr. Ornelas, for your presentation. My question is regards to dissemination and translation of your Qualitative intervention program or screening program. Have you had a chance to study the training process for the navigators and evaluate that? And if so, I'm interested in how might that feed into translation work to replicate the program.
So we did kind of bare minimum training in the first pilot and learned from that we needed more. And so they had 3 full days of MI training in Spanish and then a lot of role play work. And like I said, they were on staff for at least a month, if not more, learning protocols, doing role plays before they ever actually recruited a participant. And I think that helped. We also had ongoing supervision we had a great research coordinator who was supervising them, but also ongoing monitoring of the MI. So in our staff meetings, we listened to sessions that they had done the week before and, talked about, okay, what went well in this session, what didn't go well in this session, how might you do this differently? We had the MIghty coding of the, which is a way of assessing the, adherence to the protocol in the motivational interviewing, and we got great results. And so I think all of that helped me see what is required for training. I do think promotores can absolutely be trained to do this, and I'm excited to show that, more in future work and in this paper that's coming out, because I think this is it's a great model and could be, used for other health problems. And, yeah.
I really enjoyed the way in which you began to frame your presentation in terms of the stages of migration. And I was wondering how that continues to frame some of the interventions which are perhaps more restrained by the design.
Right.
Go back to that framework and address some of those stages.
Yes, so that's a great point and great question. So I think of Pura and ALMA is sort of really incorporating what's happened to the men before and during migration into the intervention in some way. So not taking them just as what's happening to you now, but in that conversation, the promotores, like we did a lot of training also on immigration related stressors and what happens. And they were immigrants themselves. They know where they've, come from and what has happened in that context. So I feel like just really trying to embed that into the intervention and not just focus on life, like it just started when they crossed the border. And in Alma, we also use vignettes. So we use stories, and that's part of the new design that sort of integrates the yoga and mindfulness. We're going to use more vignettes, which have been shown to be helpful, actually, in cognitive-based therapy with Latinas that have depression, have sort of the memories of the immigration experience, and I think that will be effective too. One more question? Okay.
I was just wondering if you could speak to why there wasn't any sort of a group element in the Vida Pura intervention.
Yeah, it's because we were adapting something that was already evidence-based. We wanted to stick to that one-on-one format. And I think that actually makes the most sense with this behavior too. We actually started in the pre-pilot work, the formative work. I had thought I would do focus groups with men about their drinking, and that really did not actually go very well. It was like there was a lot of like masculine and macho, like, oh, well, you drank that much, I drank this much, so I didn't feel like I was actually getting helpful or accurate information. And so I do think they're able to disclose more in the one-on-one